Now, coming to relapse, and the same term, we call it, flare, is the same term. It means recurrence of the symptoms or have appearance of new symptoms due to the active vasculitis after achieving remission. Could be any time, a month after remission, 2 months, a year, 5 years, could be any time, could be on treatment or off treatment. And why is that? Relapses are very, very common in vasculitides because they are treatable, but they are not curable conditions yet. Our treatment does not cure vasculitis. For example, in GCA patient, the relapse rate is almost more than 50% of cases, and most of them, they are during the first year of diagnosis. Female gender, patients with the arm and the extremity claudication phenotype, patients, they are treated less than a year with glucocorticoids or prednisone, they are at higher risk for relapse. Second one, polyarthritis nodosa, and I mentioned usually the relapse in polyarthritis nodosa is not that common, between 2 to 25%. And then ANCA vasculitis patients on treatment is 5%, off treatment up to 80%. And usually predictors for relapse for ANCA-associated vasculitis patient, anyone who had previous relapse, anyone with granulomatosis with polyangiitis, more than microscopic polyangiitis, someone with antigen called proteinase 3, more than myeloperoxidase, and shorter maintenance treatment, less than 24 months. But calling relapse and confirming relapse is not an easy task for the physician, and for so many reasons. First of all, symptoms are not only unique for vasculitides, and many other disorders may cause similar symptoms. Headaches is not only for giant cell arteritis patient. Vision loss also is not only for giant cells, so it could be tricky. It might be very challenging to differentiate between the chronic organ damage and between the new symptoms. So this is it needs, you need an expert in order to differentiate what is organ damage, what is a new vasculitis. We give medication, they do have so many adverse events. They increase the risk for infection, they cause a lot of blood counts and liver toxicities, a lot of side effects that may mimic the vasculitis symptoms. Then fourth, inflammatory markers are not really perfect tests. They are not only specific to vasculitis, and they might be normal in some of the patients with true vasculitis and true flare. So we cannot rely 100% on the inflammatory markers. And then we have serology, and the most common one we get asked about is the ANCA testing and the ANCA titer, in ANCA-associated vasculitis patients. So the utility of following the ANCA antibodies is really controversial, and the correlation between the titer and the disease activity, it's very controversial again, and we cannot rely 100% on it, but it's one piece of the puzzle, so we do use it sometimes. And then lastly, and the most thing we get asked about, in a clinic is the fatigue. It's something very common in patients with autoimmune disease, in someone with vasculitis. So many factors can cause, so many other disorders may cause fatigue. If you are anemic, you're going to feel tired. If you have thyroid disease, you're going to feel tired. If you have sleep apnea, you're going to feel tired. If your doctor is saying that your vasculitis is in remission, but you are still feeling tired and fatigued, it means we should look for another reason for that fatigue. Again, relapse, confirming relapse is a puzzle piece. It has 4 elements: the clinical symptoms, physical examination findings, laboratory tests, and then images.